Thank you. I'd like to thank SAGES and the program committee for inviting me to speak here today and share some of our experience with a new platform to capture, analyze data in the operating room. So throughout the years, I've received various research grants from various entities, and I have some intellectual property in an academic startup that relates to the black box. In the early days, we believed that if we hire competent, well-trained individuals and invest in training, simulation, and create evidence-based standard operating procedures and follow these procedures and invest in modern equipment, we will be safe. But we all know that that is often far from truth, and investing in safety doesn't mean that there is no risk in the operating room. I promise this will be the last time I make analogies to aviation, but because I know I'm totally aware that we as surgeons are not pilots and our patients are not aircraft. But there's a lot to learn from aviation and other high-risk industries like oil, nuclear, military. And it's mainly around capturing data and making this shift from reactive to proactive safety. I think in the past 10 years, while we've been working with Air Canada, we learned a lot about their safety practices. One of the things that I personally learned in this process is that every aircraft that they operate is equipped with a secondary black box, not the orange boxes that all of us know and are open when there is an accident, but secondary boxes that capture information from every single flight and thousands of parameters. Air Canada has been doing that for more than a decade, and even though a flight may take off and land safely, there are often things outside the norm, things that are often characterized like near misses that offer an incredible opportunity for analysis and quality improvement. So this is what we wanted to do when we implemented designed and implemented the operating room black box. One of the major limitations for us in surgery and healthcare is that the operating room still remains one of the most secretive environments in modern society. Whatever happens there stays there. And currently, there is a tremendous amount of information that we should be capturing and that should be studying, and we should be using to design better education and design better quality improvement interventions. So to summarize, in 2019, we still have fairly poor understanding of the factors that impact our performance. We talked today a little bit about performance of the surgeon, but there is still incredible variability in this performance, and often there are factors that impact our performance on an individual team or organizational level that we don't understand very well, just because we don't capture this type of information. Many of the predictive models around and risk calculators around clinical outcomes are based on patient factors or disease factors, and sometimes post-operative management, but very few of them take into account one of the most important factors, which is the surgeon and the surgical team and what happens in the operating room. We still don't have, despite tremendous investments in better safety management systems, we don't have a reliable system for reporting intraoperative adverse events, and I'll share some of our findings in that area. We don't have systematic data in that area. Still, a lot of safety interventions are primarily reactive. We wait for something bad to happen to discuss it a week or 2 weeks later at a morbidity and mortality meeting where nobody remembers what really happened. And we wait clinical outcomes to reach statistical significance to identify them and try to intervene at a point where it's very difficult to understand what are the underlying factors and what is the chain of events that led to this adverse outcome. We still blindly invest in training and technology, and one of the major failures in modern surgical training is that it's based on the one-size-fits-all approach. We create a curriculum, then we expect that everybody follows this curriculum, and the reality is that we're very different. My educational needs are probably very different than the educational needs of Dr. Schlachter, and the educational needs of our team at St. Michael's Hospital in Toronto are probably very different than the educational needs of a team in a hospital here in Baltimore or a hospital in Santiago, Chile. We spent a long time in the past few years with R&D centers of various device manufacturers, and one of the things that always struck me is that a lot of devices are developed by engineers and human factors experts and some surgeons who provide input, but once these devices are approved and get out there in the field, there is very little opportunity to gather systematic data about their performance. And performance in various situations on various patients and various tissues. There is very little data around how this device fail, or often how these devices often are designed to make us safer and more efficient, but often introduce new risks and challenges in the operating room. So that's why we developed this platform, and it basically captures information from everything in the operating room through video, audio, device performance data, and various sensors that we have implemented. All these data feeds are perfectly synchronized, and then we have the opportunity to use this data to assess various things or various areas of interest, whether it's identifying and quantifying risks and hazards, the various patterns of safety threats or resilience supports. We use it to evaluate surgical technology, new techniques, and constantly evaluate the impact of team performance, individual performance, and device performance on clinical outcomes. So throughout the years, we've had this for a few years now, we've learned a few interesting facts. One of the things that in the pilot of this technology, we looked at various intraoperative adverse events that were identified. And we asked at the end of each case, every team member to tell us, using a standardized questionnaire, whether this case was perfect or something went outside the expected course. And the interesting thing is not the number of adverse events and their classification. The interesting thing for me here was that 75% of the cases where there was a high severity intraoperative adverse event, the team felt that everything was perfect, which showed us that in current practice there is a tremendous loss of information that we should be capturing, we should be studying, and we should be using to design better targeted, individualized quality improvement and safety interventions. One of the major challenges which I mentioned earlier was underreporting, and often the electronic patient record or the operative report where we expect to find relevant information is often useless or represents a different view of what really happened in real life. And this is an example of a study that we did not too long ago, looking at various aspects of our performance and intraoperative adverse events. In this case was various needle injury. The incidence was very different from what was reported in the chart to what was observed. And also near misses or intraoperative adverse events of various severity. There were 0 reported in our database of our hospital, and at the same time we found a significant amount of those. So something else in our practice, we use this data to quantify various safety threats or resilience supports, and this is some data from our first year of data capture. We found that on average of a surgical case there are a number of auditory distractions, and this involves external communication, irrelevant conversations, non-physiological alarms, and so on. We found that there was not an insignificant number of errors and adverse events. Things that are very useful for us as teams, as individuals and teams to understand, study, and proactively address in our future educational courses or various quality improvement interventions. We also found out that the door in our operating room opens every 2 minutes, and it's a significant source for distraction. You can imagine if the door here opened and closed every 2 minutes, it will be difficult to stay on time with this presentation. We also found out that there is a huge variability in number of people in the room. And we found that having more than 8 people in the room during a standardized procedure was associated with doubling the risk of intraoperative adverse events. This was something, a study that we published fairly recently, and we looked at various device-related interruptions in our operating room, and we found that they were significant. And they're currently not studied, they're not registered, they're not addressed in a systematic way. And with this information, we are able to communicate with our teams or device manufacturers to make next generations of devices safer and more efficient, and also can introduce our teams to better education and better preparation when we introduce a new device or new technique. This was a very recent study where we looked at the impact of 3D technology in laparoscopic surgery, and we found that that led to a significant reduction of number of errors and adverse events, and also a significant reduction in average procedure duration. This is something that we will be publishing soon, and it's an example how we can use data like that to evaluate new technology and implement in more evidence-based approach in modern procurement. This was a pattern of the most prevalent safety threats in our operating room at St. Michael's Hospital in Toronto. And you can see here they were quantified and classified according to various frameworks. This is a framework that we adopted from oil industry into healthcare and then subsequently validated. And again, it showed in a very systematic way what are the things that often introduce risks or increase the risk of failure during a surgical procedure in our operating room. And I can tell you we've looked into similar approaches in other hospitals where the black box has been implemented, and I can tell you that the patterns of these risks in one of the operating rooms at St. Michael's is totally different than an OR in Amsterdam or New York. We also not only look at safety threats, but also resilience supports. These are things that allow us, despite failure and variability and malfunction, to still achieve good clinical outcomes for our patients. And these are things and behaviors or sometimes devices or safety measures that we should be aware of. These are behaviors that we should be promoting and making sure that they are a standard component of our everyday practice. One of the interesting things here is we always assign the various safety threats or resilience supports to various categories, from task to tools to technology or physical environment, organization, and so on. One of the interesting findings here is one of the biggest threats in our operating rooms is also the most resilient, the individual. We still rely on individuals to identify risks and mitigate risks, but how incredible will it be if we can introduce standardized measures like checklists and computerization and enforcing functions. I think it will make us much safer and reduce variability in our operating theater. So to summarize, I think it is very important to study and critically reflect on our performance. It's very important to introduce modern principles of high-performance organizations like openness, transparency, accountability. We need to introduce in our organizations a culture that allows us to tolerate error because then we can study it, we can recognize it early, and we can definitely learn from it. We need to use a data-driven approach to individualize education and quality improvement. And I think one of the major lessons that we learned in the past few years after we implemented this initiative is that improving performance and surgical safety are impossible without changing the culture, which obviously is not going to happen overnight, but it's a process that needs to come from our profession because we owe it to us and to our patients. Thanks again for the invitation and for your attention.